So to start off, I'm going to introduce a former fellow of ours last year, a friend of mine, Asra Tubaye, and she's going to present on drivers of junctional failure in cement augmented thoracolumbar posterior fusion constructs. It's one of our studies, so thanks for doing this.
Okay. Good morning. I have no financial disclosures, relationships to disclose. By now we all know that PJF is a significant complication after adult spine deformity surgery, and cement augmentation at UIV, UIV plus 1 or both is commonly used to mitigate this risk. We still don't know the full impact of the surgical construct configuration and alignment on PJF risk in this population. The purpose of this study was to identify perioperative radiographic and construct-related factors associated with PJF in patients undergoing thoracolumbar posterior fusions with cement augmentation at UIV, UIV plus 1. This was a retrospective review of adult patients that underwent thoracolumbar to pelvis posterior fusion. All constructs included cement augmentation at UIV and UIV plus 1. We identified patients with PJF versus no PJF at 6 month or 1 year follow-up. Then we compared demographic, surgical, pre-op, and post-op radiographic variables between the two groups. Overall, we included 85 patients in this study. 12 of them developed PJF, and half of these patients required revision surgery. There was no difference in age, gender, or BMI. There was also no difference in cement level, rod material, UIV level, pre-op and post-op global alignment parameters. In terms of the surgical construct configuration, PJF groups had significantly higher number of rods, more number of pelvic screws, and shorter accessory rod distance to UIV, all emphasizing the fact that excessive construct stiffness can increase stress at the upper junction and predispose the construct to mechanical failure. In terms of alignment, the PJF group showed greater postoperative thoracic kyphosis and greater increase in thoracic kyphosis from baseline, pointing to the fact that greater change in thoracic kyphosis or greater correction of thoracic kyphosis can increase proximal junctional stress and mechanical failure. The majority of our patients had T4L1 PA mismatch outside the target range. Most of them were in the non-PJF group, indicating that potentially UIV plus 1 cement augmentation could be protective in malaligned patients. After running the multiple regression analysis, independent predictors of PJF were post-op thoracic kyphosis, change in thoracic kyphosis, accessory rod distance to UIV, and number of pelvic screws. In conclusion, PJF is multifactorial. Stiffer constructs and greater thoracic kyphosis increase risk of junctional stress and mechanical failure in this group. And cement augmentation at UIV, UIV plus 1 may offer protection despite sagittal malalignment. Thank you.
Thank you, Oscar. That was great. So yeah, hanging out us here, we'll do some questions after the first group. Our next speaker is going to be Zach Rowe, who's going to be talking about upper thoracic versus lower thoracic UIV in adult spinal complications.
Hello, everyone. My name is Zachary Brum, and I'll be presenting upper thoracic versus lower thoracic UIV in adult spinal deformity patients with a low pelvic incidence, risk factors for revision operations for proximal junctional failure kyphosis. No disclosures. By way of background, pelvic incidence, the pelvic orientation, determines thoracolumbar shape. Rizzulli classification describes various thoracolumbar spinal shapes as described by pelvic orientation. And on the figure on the right, you can see the 4 types, with type 1 and type 2 having a sacral slope less than 35 degrees, type 3 between 35 to 45, and type 4 between greater than 45 degrees. With the difference between type 1 and type 2, you look at the just tilt angle apex within L5, it is type 1, and within L4, it's type 2. Patients with a low pelvic incidence correspond to Razuli type 1, and these patients have a very unique shape with over 75% of lumbar lordosis concentrated between L4 and S1, resulting in very sweeping long hyperthoracic kyphosis. The figure on the top right demonstrates SL distribution according to pelvic incidence by Razuli type, and what we can see here is that Razuli type 1, indicated by the black dots, have a very high SL ratio and low pelvic incidence, meaning that they have a very high proportion of the lumbar lordosis concentrated in a distal lumbar segment. The figure below it demonstrates a very strong inverse relationship between pelvic incidence and SL ratio. In these patients, it's very difficult to restore appropriate spinal shape, increasing the risk of PJK. Therefore, our question is, does UIV for thoracolumbar instrumented fusions to the pelvis dictate PJK rates in low PI patients? The purpose of this study was to evaluate rates of PJK and associated revisions in low PI patients, comparing upper thoracic UIV to lower thoracic UIV levels. In terms of methods, this was a single center retrospective review of low PI patients who underwent thoracolumbar instrumented fusions to the pelvis for ASD. We had our low PI patient cohort and divided them into a lower thoracic UIV termed LT with a UIV between T8 and L1, and an upper thoracic UIV termed UT with a UIV between T1 and T7. Clinical, demographic, and radiographic data were collected. The primary outcome was revision surgery for PJK with multivariate logistic regression used to identify independent predictors within each group. Overall, the cohorts were very similar, the UT and LT groups. However, the LT group did have a higher rate of vertebroplasty in greater proportion of females. There were similar rates of PJK and revision operations to address PJK in both groups. We first looked at the univariate predictors of revision due to PJK, and what we found was that in the LT group, univariate predictors of revision due to PJK included lower preoperative PI-LL mismatch, greater postoperative T4-L1-PA, greater postoperative T4-T12 kyphosis, greater postoperative PT, and a smaller operative reduction in both PT and T4-PA. In the UT group, no univariate predictors were identified, and UIV level itself was not associated with revision due to PJK. We then performed a multivariate analysis for predictors of revision due to PJK, and in the LT group, we found that preoperative PI-L mismatch being lower, greater postoperative T4-L1-PA, greater postoperative PT, and a more negative operative change in PI-L mismatch were associated with revision due to PJK. In conclusions, the PJK rate around 35% and the revision rate between 12 to 14% were similar between the upper thoracic and lower thoracic UIV levels. Sagittal malalignment parameters, specifically increased PT, increased T4, T12 kyphosis, and increased T401PA, predicts PJK and revisions only in LT constructs. Therefore, stopping at a UT UIV may better control reciprocal thoracic kyphosis and lower PJK rates in low PI patients. When using an LT UIV, minimizing postoperative malalignment, T4L1PA, is key to preventing junctional failure. Thank you.
Zach, that was great. Our next talk is going to be Peruz Faraduni, who's going to tell us about preoperative teriparatide usage.
Hi, everyone. Today I'll be discussing perioperative teriparatide versus bisphosphonate usage in osteoporotic patients using a national database. I have no disclosures. So the preoperative risk of undergoing osteoporotic patients undergoing fusion surgery has been documented, and we wanted to evaluate the benefits and analysis of whether teriparatide had any advantages over bisphosphonates in those patients. Currently, the literature suggests that there's minimal studies comparing the two. Most of the studies done currently on this topic are comparing bisphosphonates and teriparatides versus control, or are only in single site studies with low N numbers. This was the first time we were conducting a national database query to address this issue. So the question that we asked was to compare the outcomes in osteoporotic patients using teriparatide versus bisphosphonates usage within 1 year before fusion surgery. For methods, we queried the national database Pearl Diver from the years of 2010 to 2023 Inclusion criteria included fusion surgeries with the CPT codes listed above, who had ICD-10 codes for osteoporosis as indicated, and baseline demographics and comorbidities were compared, and complication rates between 90 days as well as up to 10 years were compared using two-sided statistical analysis. Baseline analysis, the cohorts were pretty similar. Teriparatide cohort tended to be a little bit older than bisphosphonates, but beside that, no significant difference was found within the comorbidities of the two groups. In the univariate analysis, within 90-day outcomes, there was only a few differences. The pneumonia rates were significantly lower in the teriparatide cohort. Wound infection rates between 2 to 5 years were statistically significantly lower in the bisphosphonate group. Non-significant trends favored teriparatide, namely acute kidney injury, deep vein thrombosis, risk of transfusion requirement, as well as development of UTIs. In conclusion, first, I wanted to address the limitations of the study. This is a retrospective study, so causation can't be assessed. And there was also a small sample size for teriparatide of only 92. In conclusion, there was slight superiority in perioperative outcomes for teriparatide. The baseline characteristics were similar enough to make some comparisons, except for age. And there were some non-significant and some significant outcomes that favored teriparatide, but overall, it seems that both medications are effective in promoting bone promotion before a fusion surgery. For next steps, we would want to conduct a multivariate regression to make sure to address for confounding variables. Thank you.
Thank you, everybody.
We'll open it up for a couple of minutes of questions. Any questions from the audience for our speakers?
Asra, thank you very much for your paper. I saw thoracic kyphosis, but how about thoracolumbar kyphosis? Preoperative thoracolumbar kyphosis, was that part of your study? Because I think when you stop at the thoracolumbar junction with thoracolumbar kyphosis, there's always a little bit of a greater risk.
It was, and there was a significant difference, T10 to T12.
Okay, great.
Yeah.
Yeah, so on that same paper, said it that way. What was the mechanism of failure in the patients who had cement? So the rate of failure was similar, but did you see any difference in mechanism? Meaning, was it a fracture of the UIV +1, or is it more of a subluxation problem, which is less characteristic of the lower thoracic spine?
I defined it as fractures, and looked at it as fractures. They all had fractures. I had UIV +1, but the non-PJF group had one of them only had fractured UIV +2. Oh, sorry. Yeah. So, yes, there was fracture.
I can speak up. It's for the second speaker. You talked about lower thoracic versus upper thoracic endpoints in more than one patients. With the lower thoracic endpoint, what was the UIV? Because often with those patients, you're into the lower thoracic spine, getting awfully close to the apex of kyphosis.
It was between T8 and L1 for the UIV for that cohort.
That's a big spread. Okay. Any thoughts to stopping a little bit lower than L2 on type 1?
I mean, yeah, that's a very good point, and something that we could definitely look at in terms of a sub-analysis to tighten that range.
I don't want you guys falling asleep. So for the second paper, I think it's a great idea, but I'm almost more interested in the high PI people. Because the high PI people are the ones that I think get into more trouble because either we don't get the low lumbar lordosis to mimic or to counteract their PI. So, have you studied that population? If you haven't, I would recommend looking at lower thoracic versus upper thoracic in that high PI people. And I think, like Mike Kelly said, it's a spectrum. So just make it more than 50 or whatever, and not a Russley classification. But I wanted to know from you, like you said, like the first paper said that T4L1 didn't really matter in her case, but you said if you go lower thoracic, you better pay attention to T4L1. So can you guys duke it out and tell me what's the truth?
I mean, want to go first?
So I looked at PJF and you looked at PJK.
Yeah.
And you had cement augmentation, right, in your study of UAV and UAV plus one?
Mm-hmm.
So I know that, so patients could still develop PJK, but not necessarily PJF in presence of cement augmentation if they're malaligned. That's what I'm getting out of this.
I mean, in terms of our study, looking at the LT group, T401PA did emerge in the multivariate analysis as like the most predictive variable for that group. And we were looking at for revision surgery for PJK. So, yeah.
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 And I was looking at the PJF.
Correct. Yeah. Yeah.
Yeah, complicated topic. There were differences in the type of cement that was done between the two groups and the other prophylactic strategies at the proximal junction. So I think there may be some differences in surgical strategies. And the first paper were all comers, different PIs, where the second one was more focused. So I think that's a good question of whether the T4 L1 PA access is applicable to everybody, or if it's more focused on one type of PI patient or not. All right, thank you guys. Come on down. So our next study will be given by Ryan Wong, and I was introduced to Ryan by one of our other fellows, Austin Katz, and this is the first time I'm meeting him in person. So he's done a lot of great work. He's going to present on long-term revision rates for posterior-only operations for pediatric and young adult deformities and national database analysis.
Yeah, thanks for having me, Dr. Theologis. My name is Ryan, and I actually think the slides might be switched. Sorry. Yeah, but I'll be first presenting today on a national database study looking at longitudinal reoperation rates, mainly for adolescent spinal deformities. So thanks for having me today. Next slide. Yeah, so I have no disclosures. And then for a bit of background, so particularly for adolescent deformities, for example, there's like adolescent idiopathic scoliosis. Generally, the standard of care is doing a posterior spinal fusion. And even though this is like a relatively not too well-studied field, so there's pretty limited literature looking at longitudinal reoperation rates and medical outcomes in this population. So basically, we were basically wanting to look at, with a national database, just these longitudinal outcomes and just basically classifying the outcomes after PSF in these patients. So in terms of the methods, we utilize the Pearl Diver Mariner database. So that's just a large insurance claims database. And this sort of allowed us to use a larger patient sample that previous studies looking at pediatric or adolescent deformities haven't been able to. So particularly, we looked at data from 2010 to 2023, and then we were looking at patients aged from 10 to 25, and then our exclusion criteria was basically patients who had any anterior fusion or just a previous history of thoracic vertebral fracture. Primary outcomes we were looking at in our cohort was just 90-day medical complications, so like acute kidney injury, blood transfusions post-operatively, and then sort of the primary outcome of our study was looking at longitudinal reoperation. So we basically looked at less than 1 year, 1 to 2 years, 2 to 5 years, and 5 to 10 years. And basically, we just wanted to sort of classify the success of these procedures longitudinally. I do want to clarify that this is a descriptive study because we just didn't have a comparison group, but since it hasn't been too well studied, we just wanted to make sure we could classify these outcomes. So it's just a descriptive study. So in terms of the patient sample, so there were 2,457 patients aged 10 to 25 who were undergoing posterior fusion for spinal deformity. The average age was 14.3. The comorbidities were like relatively low in this cohort. There wasn't a comparison per se, but this is just the characterization of our cohort for this study. Regarding the complications and longitudinal outcomes, so within 90 days, the medical complications were relatively limited. The most significant one was pneumonia with a 9.3% occurrence. The remaining medical complications within 90 days were relatively limited. Looking at the wound infection and reoperation rates, within 1 year of surgery, it was an 8.1% reoperation rate. Notably, after that, looking at sort of longer term outcomes till 10 years, that if patients were able to make it past the first year, that the reoperation rate did decrease pretty significantly down to like 3% and then 2 and less than 1%. So mostly if the patients were making it past the first year, outcomes were pretty successful. Another thing that we looked at in our study were reasons for reoperation. So among these patients and why they were being taken back to the OR, we looked at, fusion, osteotomy, implant removal, device reinsertion. Based off what we found, the primary indications for reoperation among these patients was generally implant removal and device reinsertion. So that kind of just gives us an idea of why these patients are being taken back to the OR. In terms of conclusions, this descriptive study just characterizes the medical complications and then the longitudinal reoperation rates after posterior fusion for adolescent spinal deformity. For the most part, the complications and reoperation rates were in line with other spine surgery with less than 10% within 1 year. And then, that would lower longitudinally to 10 years. And then in terms of future plans for what we're hoping to do, we're also going to do a sub-analysis looking at specifically patients with AIS versus without AIS, sort of seeing if there's a risk factor for outcomes in those patients. Thank you.
Thank you, Ryan. The second study will be given by Peruz Ferranduni, minimally invasive versus open SI joint fusions, complications, and reoperation rates in a national database analysis.
Hello again. So if it seems like a lot of our methods are very similar, Ryan and I are actually roommates. He's a great mentor of mine. So just wanted to, I guess if that's a disclosure that I need to make, I just made that. So this, as Dr. Theologis just mentioned, this is a comparison for patients undergoing sacroiliac fusion with a minimally invasive approach versus an open approach. And again, this is a national database analysis. So sacroiliac joint pain roughly accounts for 15 to 30% of low back pain, and according to some studies, has been shown to be very underdiagnosed. As a result, there has been a uptick into the usage of sacroiliac fusion as a means to address that. To date, there's been no clear conclusion reached comparing the efficacy of minimally invasive versus open approaches. According to my literature review, I was only able to find one comparison, and that was in a single site, or it was a multi-center study, but there was only about 200 patients compared. So we wanted to broaden our view of this into a national database and ask the question of what outcomes differences are there between minimally invasive approach versus open SI fusion. We queried the Pearl Diver National Database to include patients, adult patients defined as age of greater than 18, and those who have undergone SI fusion codes. The codes for 27280, I believe, is for open surgery versus 7.9, which is for minimally invasive, and baseline demographics and comorbidities were compared using as well as the complications between 90 days and 10 years post-operatively using two-sided statistical comparisons. For baseline comparisons, there were some significant differences. The MMI group tended to be older, but had better comorbidities, anemia, COPD, cancer, chronic kidney disease, pulmonary disease, CHF, coronary artery disease, hypertension rates were lower in MMI. The only notable distinction from the trend was that obesity rates were higher in the MMI group. And for complications and outcomes, AKI, deep vein thrombosis, hematoma, pneumonia, pulmonary edema, blood transfusion rates were lower in MMI compared to only UTI being lower in open fusion, and reoperation and wound infection rates within 1 year, as well as wound infection rates within 5 to 10 years were lower in minimally invasive approach. Limitations, again, given the retrospective design of the study, no causation can be established. Given the conclusions, with the big caveat that the cohorts were significantly different in some regards, with that caveat, MMI seems to favor lower early complication rates as well as lower reoperation and wound infection rates on the long term. These findings support the potential safety advantages for a minimally invasive approach, underscoring the need to interpret the results further. For next steps, and these are big ones that we're undertaking currently, is to do multivariate regression and propensity score matching to kind of compare the cohorts more similarly and adjust for co-founders. This is just a slide that I put in from the manuscript that is coming up about the trends of SI fusion over the past 13 years. So as you can see, there's been a significant uptake. The 2023 data is erroneous because only the first quarter was included, but the trend still exists. Thank you.
Great. Our third talk will be given by Timothy Kim. Title of the presentation is Leveraging Personalized Interbody Implants for the Minimally Invasive Treatment of Adult Degenerative Scoliosis.
Great. Good morning. Thank you for having me. I'm at PGY4 at UCSD in the neurosurgery department. So I don't have any particular disclosures. So for background, as we've learned this weekend, adult spinal deformity correction, very challenging, and there's lots of complications. There's major surgery and implant adverse effects we see, and even the revision rate can be quite high. And part of the way that you're trying to tackle that challenge is trying to personalize deformity correction for that patient. And so what are the tools we can use to do that? You have robotics, we have patient-specific rods, and then, for the purposes of this talk, personalized 3D printed interbody cages. So here's just kind of a picture of what that looks like. You take the CT scan preoperatively, and you're able to essentially get a 3D rendering of the implant that you want for that specific level, and you can get the different measurements as you see over here. You can see in the sagittal plane what it would look like preoperatively, and then what it looks like corrected with these different inner bodies at every level. So you can see in the sagittal plane, and then you can even get really good coronal correction too with these inner bodies. There's been a couple papers so far, mainly in open deformities, showing some preliminary evidence of the safety and also just efficacy of these personalized inner bodies, and showing that when it comes to radiographically, they're able to reach these goal alignment parameters better than relative to the stock inner bodies. So this was just a single surgeon retrospective case series of consecutive patients with adult degenerative scoliosis who underwent minimally invasive reconstruction with personalized inner bodies for correction. So there's 12 patients. They underwent, stage 1 was an OLIF/lateral ALIF, and then the second stage was robot-assisted, minimally invasive placement of posterior instrumentation with multiple rod constructs. So this is kind of what it looks like preoperatively when you're designing it. As I said, you take the CT preoperatively with the thin cut slices. You're able to disarticulate each vertebral or each body or the segment. And then based off of whatever parameters, you can work with the engineers to meet whatever lordosis you want at that level. You can look at the coronal angle, things like that. So this is kind of what it looks like for the first stage for when we do the OLIF/lateral ALIF. Most of these patients got L1 to pelvis, so that bottom incision is for the lateral ALIF or 5-1, and then that other incision more laterally is used for the rest of the inner bodies. Then we get an interstage X-ray after stage 1. You can see that already with the inner bodies, we're getting good coronal correction. And then we get a planning CT for just planning the posterior instrumentation that we will do robot assisted and make sure that the screws are all aligned well and that the rods will fit. And this is kind of what it looks like in the posterior doing transfascial pedicle screw placement with the robot. Some results. So levels, it was average of 10 levels, 5 cages, and about 3 points of fixation for to the ilium as well as rods. And then operative time about 3:30 for the stage 1 and 3:80 for stage 2. So in terms of the radiographic parameters, we got scoliosis correction to about only 7 degrees postoperatively, then 38 degrees for L4 to S1 lordosis, about 2 degrees for PIL mismatch, 3 degrees for L1PA from target, and then the post-op, the mismatch of T4 L1PA about 4 degrees, and about no complications related to the inner bodies. So here are just some of the preoperative and post-op kind of standing x-rays and using these inner bodies and this kind of technique. And then here's some lateral standing x-rays, and you can see you get good sagittal correction as well. So in conclusion, personalized inner bodies show promise in achieving radiographic correction of degenerative scolia and minimally invasive reconstruction. Obviously, there's limitations in this: single surgeon, small series, limited follow-up and clinical analysis, and no comparison group. But, the future direction is trying to compare it with some of our previous data with using the stock inner body spacers. I would like to do a multi-center study with these inner bodies, and then also evaluation of the proms. And as we've learned this weekend, some of the mechanical failures can take 5 to 10 years. So being able to have that follow-up would be helpful. That's it. Thank you.
Hey, last talk, Ryan. Title of this presentation is a comparison of longitudinal reoperation rates up to 10 years in multi-level thoracolumbar posterior instrumented fusions with and without concurrent anterior lumbar interbody fusions for adult spinal deformity.
Yeah, thanks for the intro. Ryan again, and then as he mentioned, I'll be going over a national database study comparing outcomes for adult spinal deformity with posterior fusion and then with and without concurrent anterior lumbar interbody fusion. Once again, no disclosures. So for a bit of background, the current sort of gold standard for treating ASD is posterior spinal fusion. Something that hasn't been too well studied, though, is sort of the concurrent use of ALIF to augment the construct. There have been some limited pilot studies, but generally with a pretty small sample size that may sort of support that. ALIF is good at reducing reoperation rates and sort of stabilizing the construct, but there isn't really any large-scale data that supports those findings. So sort of what we were trying to do here is use this large national scale database to sort of validate the efficacy of using ALIF to bolster PSF for adult spinal deformity. So yeah, that's our objective. And then in terms of methods, once again, using the Pearl Diver Mariner database. For this study, our inclusion criteria was patients with adult spinal deformity, undergoing fusion, and then also older than 50 years. Exclusion criteria was prior history of thoracic vertebral fractures. And then similar to the first study, primary outcomes were looking at 90-day medical complications and then longitudinal wound infection and reoperation rates, and similar time points, less than 1 year, 1 to 2 years, 2 to 5 years, and 5 to 10 years. So this sort of helps to characterize the sort of long-term success with ALIF and whether it's beneficial. So in terms of the baseline characteristics, so the patients that were undergoing concurrent ALIF were older than those those without concurrent ALIF were older than those with ALIF by 2 years. Statistically significant, but a relatively small difference. And then as far as the comorbidities, relatively similar comorbidity profile. There's a greater rate of depression in the ALIF cohort, 58% compared to 52%, but otherwise the comorbidities were comparable. As far as the univariate analysis, there were actually no shown differences between 90-day medical complications and longitudinal reoperation rates. That was a univariate analysis. And the multivariate analysis actually showed that ALIF was associated with lower rates of reoperation at 2 to 5 years, approaching significance, and then also lower at 5 to 10 years. And it was actually like about 1/3 at the rate at 5 to 10 years. And then as far as medical complications, ALIF was associated with increased rate for acute kidney injury at 90 days, but no other medical complications otherwise. So in conclusion, it does appear that concurrent ALIF done for ASD does have some benefits for sort of longitudinal stability of the construct, reducing reoperation rates. But on the flip side, there are additional risks associated with the additional surgery. So keeping in mind sort of the additional medical complications that might be incurred. As far as limitations, similar national database, not really as granular, but definitely good for informing sort of large-scale data for these procedures. Thank you.
We'll open the floor to questions.
Thank you, gentlemen, for all your hard work. It's really great to see. Question for the paper on the personalized interbodies. Manish and I were talking, a lot of your interbodies are at upper lumbar levels. I even saw one, I think at L1-2 and L2-3 on one of your x-rays or one of your films there. What is the reason to put interbodies at those levels from your perspective?
Yeah, I think my understanding is part of it is helping with the coronal correction at that area.
Okay, I just want to highlight a point that Manish made yesterday, which is, that when you fill the interbody space at these upper lumbar levels, you block your correction capability because you basically overstuff the disc space and it doesn't move, right? And I think that I went through this for about 10 years myself, putting interbodies at those levels, and then I realized, it's not really absolutely necessary. So it's just a question. The second question really is, I haven't gone down the personalized interbody road yet, even though people have been pushing me to do that. From your perspective, is there a certain lumbar level where it's most beneficial?
I have very limited experience with this, but I would say, that 5-1 level I found very helpful. We use it in both ALIFs, supine ALIFs, standard ALIFs, and the lateral ALIFs. And I've done them without using the interbodies I guess some of it's also with the surgeon I'm working with, but I found them much easier, and the kind of correction you can get and the lordosis restoration is pretty good at that 5-1 at the bottom level.
I was actually expecting a question about cost, just like for yesterday. The interbodies, the interbodies up at L1-2, 2-3, mostly because all of those were circumferential MIS. So there's nothing opened in the back. So pretty much from L1 to S1, the patient is relying on the interbodies for fusion. Right, so everything else above that, there's some data that shows out of the Japanese literature, they actually don't decorticate the facets at all. I'll still decorticate facets. And I know Mike Wang used to put BMP, some people put chips, some people just drill. But for every one of those cases in the cohort, they were circumferential. So it's just screws through the fascia, and there's only bone graft I could put through the transfascial incisions. But otherwise, they're relying entirely on the interbodies for fusion. So that's the reasons to go essentially as high as I can.
And do you do that all the same day?
It's staged. So laterals are 1 day. So lateral to cubitus is stage 1. So L1 to 5, OLIF, 5-1 lateral ALIF. And then I rest them a day to get the CT. And then the posterior is a second stage. I used to do it in 1 day. As some of the maybe older residents will remember, it's just a very long day. So now, I think like many people who do MIS, I just stage them.
What would you say is your average length of stay for, complete MIS procedure?
Yeah, the promise of MIS is that they get out of the hospital sooner. I'll stay in honesty, it's not always the case. I've had someone leave the hospital on the 3rd day after stage 2. So it was a Friday end for stage 2, and they left on Monday. I've also had people leave and stay like an entire week. And it's mostly just for muscular recovery. Again, for MIS, I do operate on people who are a bit sicker. So I operate on people who are BMI 40, 41, 42. I operate on folks who are, say, 76, 77, because I'm more comfortable with the operative complication risk, which is lower. And so sometimes I think my length of stay, as much as people can get up on the podium and say it's faster, I think it averages about the same. But I think, overall, the ability, though, is to potentially operate on people who are a bit more frail or less candidates for open surgery.
Very nice study and great correction. Question about how you would do a single stage with the use of the robot. My understanding is that if you do the inner bodies, you need to get another planning CT to plan the screws. How do you do it on the same day?
So, that was always the recommendation from any of the robot manufacturers. They always recommend that you get a CT. I will say that some systems are better at capturing the vertebral body, even if there's something in between. So for the first 5 or 6 cases, I would do inner bodies. They'd be titanium. And then, of course, the pre-op CT captures a pre-op of the spine. So when we flip them prone, it would be more difficult, but they would still capture it. So, our rep, I know he had to leave, Carlos Rivera. He's been with me since 2019 when we got the robot. We started doing this in probably 2020 late. And it's a very technical thing. You have to get certain x-rays at a certain angle. So it's beyond what the companies teach you. But it is possible. So it tells you the capabilities of the system where we were still able to do it. The limitation wasn't the robot. It was just like my own fatigue by the end of the day. But even with titanium inner bodies that block multiple end plates, it took a little bit of changing the C-arm because I would do a CT to fluoro. We were still able to capture it. And it was still doable, which tells you kind of the advancements of the robotic systems now for registration.
The x-rays are so beautiful, and I love the way you contoured the rod up top for the lower thoracic spine. My question to you is, there must be some selection in your mind how you choose between MIS, right? Age, the levels, because I believe that staging is not only beneficial for fatigue of the surgeon, but also for the patients. They get extubated and they come back, they get extubated again. Sometimes when you do it all day, it's a long day, they try to keep them intubated, which is hell for the patient, right? More complications. So what is your selection criteria on who you choose to do this? And, do you do something else for the other ones with like worse deformity? Do you study them with CTs, look at what is your algorithm? Because I think that's important for the audience to know.
I think naturally it's all of this, hopefully, as many of the people in the room will see, it's just tools in your toolbox, right? I trained, like Joe and many of the others in the audience, I trained with Larry, for apprenticeship for a year in open surgery as a gold standard. So I think, my goals and selection criteria, if they've had prior fusion, prior surgery, if it's a large deformity, it's, you can't bend the tool of MIS to achieve correction, and that's still going to be the ultimate goal. So many of these are moderate deformities. I think the most Cobb angle I've done in the thoracolumbar spine for a degen scoli is maybe 55, right? And so anything more than that, or if it starts to get into a thoracolumbar spine or higher, it's just not going to be an MIS surgery. If they've had prior instrumentation, like one of the cases, I don't think a part of the slide deck that we had presented at home, it was a lady with a 3-to-1, and she's very flat. So that was someone I did a PSO on. But at least with all of these technologies, it was ACRs and a PSO below that, and it was a mini open. right? So there are certain things that you can still reduce risk, and it's a blend here. But ultimately, in terms of correction, it's just what alignment I think I can get. If it's not 5 interbodies, it's going to be a PSO, or it's going to be an ACR, it's going to be a combination of all of those.
Martin, I'll give you a little break. It is interesting, though, to think about learning from other people's workflow, because I can't think of a time where I've actually staged a front and back 10-to-1. So yeah, it's just sort of interesting to think of what makes that so exhausting. But let me go to a couple of questions about the large database studies. The first one on AIS, patients aged 10 to 25, and the revision surgery reason. Were you able to really get that out of a large data set in terms of, you talked about implant removal as well as re-instrumentation. Well, did that tend to be extension of the fusion cephalad or cauda? Did it tend to be implant removal for pain, or what was the reason for the reoperations?
Yeah, so one of the limitations of the database and sort of how we got the data for the reoperations, so we basically, the way we coded it is that we were asking the database, like when, if there was a procedure done within a given amount of time, and then we were able to see like which CPT codes were done for it. But because it's basically coded in like ICD-10 codes, it wasn't really feasible to figure out the reason for that. So to answer your question, yeah, we weren't really able to granulate that in terms of the diagnosis for the reason, but we were able to figure out, like which CPT codes were performed for the reoperation.
And that's probably a limitation that's difficult.
Yeah,
to
one of the
overcome.
big limitations. Yeah.
And in Perez, with regard to your study, specifically, now you're going to remind me, the SI joint. Yeah, thank you. No, the ALIF. You did the ALIF one as well, right? All right. Well, let me get to the ALIF one. Probably the same question is in terms of the ALIF. Were you able to show why that might have been protective in terms of revision surgery? Was it pseudoarthrosis rates? Did it have to do with better alignment of the spine, or why was that relatively protective?
Yeah, I mean, I think, as far as the database limitations, we weren't really able to figure out the specific reason. I think biomechanically, sort of what I've seen in like previous literature is that, the ALIF is meant to augment sort of the stability of the construct. But it is difficult from like a national database standpoint to figure out if that's precisely the reason why. So I think that in terms of future studies, looking at specifically why it stabilizes it would be beneficial. But as far as like the limitations of the database, it's difficult to know.
Let me ask one for Perez. So specifically with the SI joint, differences between open and MIS, was more likely S2AI screws versus iliac screws, or was there a difference in a number of screws between those two techniques?
Similarly to Ryan's answer, so the main coding was also through the CPT codes, so the granulation also isn't included. The main outcomes that were considered were the ones in the second table that I showed, the AKI, the transfusions, all of those. But as for the granulation of like which levels, we don't have that data, unfortunately.
All right. Well, thank you, everybody. Thanks, guys. And also thank you to the audience. I really appreciate everybody showing up to support our students, residents, and fellows. I think let's maybe take a 10-minute break, top off the coffee, splash some cold water on our faces, and then I'll come back. It's going to be a really exciting session right after this.